It's my pleasure to introduce our next speaker, Dr. Sammy Saab. Sammy received his BS, MD, and MPH from UCLA before leaving to go to UC San Diego for his internal medicine residency. He then returned back to UCLA to complete his fellowship in gastroenterology, hepatology, and he's a longtime faculty member here in the division. Sammy's going to be talking to us about cirrhosis today.
Well, good morning, everybody. Good morning. I'm filming church. But I want to thank the organizer for asking me to speak today on cirrhosis, very, very important topic. So the title of the talk is Clinical Advance in Management of Cirrhosis and Its Complications. In the next 20 minutes, we want to cover 3 objectives. We're going to talk about diagnosing cirrhosis and how to assess its complications. We're going to review the natural history and talk about how to prevent and treat these complications of cirrhosis. So cirrhosis is a major public health concern. Cirrhosis is associated with yellow eyes, jaundice, ascites, liver cancer. The problem is the prevalence is pretty unclear. And many people with cirrhosis could have cirrhosis for years and be undiagnosed. We think about 1% of the population has cirrhosis. We saw some of the physical findings of cirrhosis, spidangiomas and pulmonary edema and jaundice. We people so yellow come to the clinic, turns the lights off, and their eyes are fluorescent yellow, lights up the room. We had a lady not too long ago who was adorned to the hospital, was getting her routine blood tests and found to have elevated liver enzymes. We see her. We examined her, and her chest was full of these little red spots called spidangiomas. Ascitic is a sign where people have high ammonia levels that lead to encephalopathy. Other signs of cirrhosis are ascites. Can anyone guess how much fluid there is in this person's belly? God, about 13, what was that? 13? Yeah, I would say 13, 14 liters too, quite a bit. Can you try your shoelaces, all that water in your belly? Try to take a deep breath with all the water pushing on your diaphragm. You can't even eat a full meal because all the ascites pushing on your stomach and you get early satiety. And lastly, edema. These are some physical findings that lead to a diagnosis of cirrhosis. So one of the cardinal things about cirrhosis is that people lose muscle mass. So early cirrhosis is still have well-maintained muscle, but over time, so muscle mass has temporal wasting. And it's fascinating. The muscle mass is correlated with the development of ascites and associated with encephalopathy because muscles play a role in detoxification of ammonia. People with cirrhosis are in a state of starvation, and it's important to maintain their muscle mass. We tell our patients to eat 3 meals a day and a bedtime snack. But doctor, I get full when I eat a meal, a piece of steak or chicken. Because all the water pushes your stomach, get early satiety. So we encourage protein supplementation in terms of shakes like Ensures or Boost. And if they get too expensive, buy Carnation instant breakfast and make your own shake at home. So another question comes up a lot with cirrhosis is medications. What can I take or what could I take? Some things are very, very obvious. People should not take aminoglycosides because they cause kidney failure. Shouldn't take non-steroidals, cause kidney failure and increase the risk of internal bleeding. People say, what can I take for pain then if I can't take my Motrin or Advil? What can I take? Tylenol. No, they told me that kills your liver. Yes, we take a whole bottle of it. But if you take a couple of days, it's the safest thing we have for people with cirrhosis. Other options are tramadol. Now, if you ask me, what impacts people's quality of life with cirrhosis? There are 3 major factors. We're going to talk about encephalopathy very shortly. But 2 other factors, believe it or not, is pruritus. People with cirrhosis, oh my God, they're always itching and they have always red marks on their backs. They can't sleep at night. The best thing for Prevalence is, believe it or not, is Atarax, hydroxyzine. Take it at bedtime. We warn them, be careful because they make you sleepy the next day. If they don't metabolize it that well. Hydroxyzine is wonderful. Makes it help you sleep at nighttime. Helps treat the reversal of sleep-wake cycle. People complain about it. Help Prevalence. The other thing that destroys your quality of life is leg cramps. And leg cramps is like a knife going through your calves. Or when you're driving a car, your hands lock up. Ugh. What do you think is the best thing for cramps? Gatorade. Oh my God, the best thing. Take a small cup a day. Don't take a whole bottle, you get swollen, right? All the salt and fluids. Small cup a day. Small cup a day. Now, cirrhosis, Dr. Evans mentioned, could come from a number of etiologies. And the most common reason today is probably hepatitis C. And fast on its track is fatty liver. Hepatitis B, alcohol, and the list goes on and on. We have a woman now in our ICU who has methotrexate-induced liver disease. Methotrexate, medications. Now, when someone has cirrhosis, it's not a death sentence. People have cirrhosis and be well compensated, walk and talk like you and me. But when they have one-sided decompensation, one side of the liver manifesting portal hypertension, ascites, encephalopathy, variceal bleed, that's where survival plummets. And that's what we target for liver transplantation. I tell people with liver cirrhosis, when you have cirrhosis, 3 things could happen to you. 1, you could develop liver cancer. Like Dr. Bevins mentioned, we have screen people for liver cancer on a regular basis. Number 2, you may get portal hypertension. But believe it or not, dying for portal hypertension is, it's not that common. From ascites or variceal bleed, control those complications. So liver cancer is one problem, portal hypertension is another problem. The third problem is liver dysfunction. And we have different scoring systems for survival. And what's inherent in these scoring systems, Child-Pugh score, Mill score, is liver function. When liver function deteriorates, that's probably the best predictor we have of survival. And for the past 10 years, people on the liver transplant list, we've been utilizing the Mill score to rank people on the transplant list. If Mill scores were 15, the benefits of transplant outweigh the risk. And inherent in the Mill score is a synthetic function. Your bilirubin, your clotting factor, INR. When those deteriorate, that's when your survival decreases too. Let's talk about portal hypertension now. Varices, ascites, enlarged spleen, and encephalopathy. Here's a picture of esophageal varices. I described this to patients. I told patients these are like varicose veins in your esophagus. Varicose veins. And anyone with cirrhosis, anyone who has cirrhosis should be screened for varices. And then here's a picture also, gastric varices. And depending on the size of varices, you may want to repeat the endoscopy in a short period of time, or even consider, banding them, or put them on a beta blocker, depending on the size of varices. Now, I'll be honest, I have a bias. If I have someone who's got varices, and they're medium or large, I don't want to reduce the risk of variceal bleed with beta blockers. I want to eliminate it. So with our hemostasis here, I think it's probably the best in the country. We ban these varices. We banned them. Gastric varices is a whole different beast. Now, someone's got acute GI bleed. You got to do the ABCs, resuscitate them, IV fluids, right? Some antibiotic to prevent infections. And in patients who don't respond to medical management, don't respond to endoscopy or triatide, we got to think about doing a shunt called a TIPS, transjugular intrahepatic porosystemic shunts. Refractory ascites, refractory bleeding are indication for TIPS. But TIPS does come at a cost. And the cost is in some people you may have problems with mild encephalopathy. That's okay, though. We can take care of it. We have drugs like rifaximin and lactulose, so people who have encephalopathy after tips. As I mentioned, one of the people who have acute GI bleed, we talk about giving antibiotics because there's a huge risk of infection transmural with people with cirrhosis. The most common manifestation of cirrhosis and portal hypertension is ascites. And the majority of patients develop ascites at some point in their life. Where you have some ascites, generally recommended is get a paracentesis, calculate the sag, tell you the water is coming from. If someone's got cirrhosis, got ascites came from cirrhosis. We deal with the ascites in a stepwise manner. Recommend a low salt diet. Salt makes retain water. How often is that effective? 10% of the time. Doesn't really work. We got to start diuretics. If the ascites is not responsive to diuretics, you talk about doing paracentesis. If the full person, you can talk about doing a TIPS procedure. Now, always confirm diet. We had a patient come here a couple of years ago to our transplant clinic because he had refractory ascites, and I asked him, "What do you eat?" "Oh, I love pickles." And do you know how much salt there is in pickles? This guy stopped eating his pickles on a daily basis, and his ascites went away. So diet does play a role. Now, people with refractory ascites should be considered for transplantation. There's a slide here talking about beta blockers, a lot of enthusiasm on beta blockers, particularly someone's got varices, but there's a window, and there's some studies come out recently, someone's got ascites, particularly refractory, beta blockers may be associated with worse survival. One of the fear complications of ascites is peritonitis. And people don't have to have symptoms or like pain or infection for this. If there's any change in their ascites condition, it's harder to control. It's getting worse. And indeed, they have fevers or pain. You got to tap the fluid. All you need is a little bit of fluid to see if there's infection. If they have SPP defined by poly count or more than 250 acidic fluid, you got to treat with IV antibiotics. Now, something in the past decade that's emerged is that people, when they have peritonitis, it leads to some of a shock in the patient, and that can lead to kidney failure, particularly hepatorenal syndrome. Just recommending now people who have spontaneous bacterial peritonitis, they should begin albumin infusion to protect their kidneys, to keep their volume status as high as possible. Anyone who's had one episode of SPP has to be prophylactic against a second episode of SPP, because the recurrent rate is pretty high, about 30-40% in 1 year. And we have a number of options here for prophylaxis, very easy, they're all oral medications and very safe and well tolerated. One of the fear complications is kidney failure. And as you recall, in the MEL score, the three components, I spent some time talking about bilirubin, INR. The third component of the MEL score is a creatinine. And if you play with the MEL score, change the INR 1 to 2, or the bilirubin from 2 to 5, it's got to impact the MEL score. MEL score goes up. But what's got the greatest impact on the MEL score number, on the value, on the predictor of survival is a creatinine. So I have people who have cirrhosis, and I tell them, listen, when your kidney goes, we're in trouble. But it's a creatinine, the kidney function is probably the best predictor of someone's survival of cirrhosis. People, when they start having kidney dysfunction, and you see here, but different creatinine levels between 1 and 1.5, their survival goes down. If someone's got refractory ascites, you see here having a major impact on survival. And there's something called the hepatorenal syndrome. And this is fascinating. So if you just think in your mind, your creatinine goes up and your output goes down. Without dialysis, with the hepatorenal syndrome type 1, people's mortality rate is 100% in 2 to 3 weeks. 100% in 2 to 3 weeks without dialysis. Now, we have hepatorenal syndrome type 1, very serious. And we have a type 2. And type 2 is like refractory ascites, difficult control ascites over a period of time, and a moderate elevated creatinine level. How do we prevent these problems? We want to be judicious with diuretics. We don't want to flood someone, give them a high dose diuretics. We also want to avoid IV diuretics. We'll put a lot of strain in the kidneys. And I mentioned earlier, avoid aminoglycosides. So I see patients sometimes for clearance for a surgery, and I always put that on my note. Avoid nonsteroidals, avoid aminoglycosides. Talk about hepatorenal syndrome. Here's a nice picture of hepatorenal syndrome again, type 1. That's a classic one, decreasing urine output, paralleling increasing serum creatinine. And within a couple of weeks without dialysis, people's survival was 0. Now, one of my favorite conditions is encephalopathy. This is fascinating. Because I'll be honest, people with cirrhosis that could be on transplants for many years. And there's a long list for transplantation. And our job as providers is to hold their hands and maintain their quality in life and their dignity. Encephalopathy is a condition that not only affects the patients, it impacts their caregivers as well. People can have encephalopathy, which means mild confusion, and it's a spectrum. And you've seen the obvious ones, right? In the ICU, where someone's on a ventilator. But you remember, there's also mild forms, where people drive on the freeway by braille. Or their reaction is very poor, and they'll get a speeding ticket. Or they get a ticket for running a stop sign. We had a patient come to our office this last December, and this guy was mad. And I go, oh my God, they have to pay a high co-payment? Did they wait a long time for us? What happened? He's a professor from Casa Los Angeles. He was mad because the past 2 weeks, he got 2 speeding tickets. We asked him more questions about his thinking, he reverses the wake cycle. And his partner says, he's forgetful, doesn't know his words anymore. This guy had minimal hepatic encephalopathy. There's a paper not too long ago showing that people with minimal encephalopathy are at risk for hip fractures. You guys remember the $6 million man? So imagine he's got cirrhosis, right? And the reaction is compromised. They're falling down. They're not going to get the railing of the chair in time. They're going to fall down and break their hip. So common signs are, again, people in a coma, they have asterixis. Now, asterixis is interesting. When you have someone stretch their hands out, if it goes side to side, that's okay. Well, not okay, but it means they're weak. Or they got a tremor. Not okay. But when they go back and forth, that's asterixis. And the less common things are seen here. How am I doing time? Good? Did Simon take my time up? I think Simon took my time. I'm going to make him pay now. All right. How do we treat encephalopathy? Very easy. Lactulose. It's a sweet. Have you guys tried lactulose? Simon, you tried lactulose? What does it taste like? He hasn't taken it. Listen, it's a sweet, awful syrup. Sweet. Oh my God, this is awful. I didn't want to be a hypocrite, right? So I tried it. One of my patients in a bottle. Oh my God, you can't take this stuff. It tastes awful. Sweet. I felt gassy after a while. I had to go to the bathroom. You pass gas. It tastes awful. It tastes awful. So we have other options. Rifaximin. Great drug, oral drug, twice a day, very well tolerated, no side effects. We have other things that we really should avoid. The Vanco, Flagyl, they don't work. Neomycin is a drug that Simon and I use in our training. Causes deafness. That's why I'm shouting so much. But don't prescribe it. Don't prescribe it. So minimal encephalopathy. I love minimal encephalopathy. Because again, our job is to improve his quality of life. We had a patient not too long ago. I swear this guy came in a wheelchair, like this, by his family. The doctor wants to make him DNR, put him out to pasture. And I had him put his hands out, flapping. Gave him a rifaximin. And my God, in a week, this guy was like walking and talking. It felt pretty good. All right. Okay, stay focused, right? Stay focused. All right, where are we at? All right, liver cancer. You guys remember Richard Nixon? Was that before your time, Mark? All right, I was a kid. I remember playing road with my brother in the den in City of Bell, and we saw Rich Nix on TV like this. He goes, what can I beat cancer? And for God's sake, he was right. Brought some money, and the Cancer Institute and cancer rates have come down in this country with a number of exceptions. And unfortunately, liver cancer is one of those exceptions. Second fastest growing cancer in the United States. And the cancer with the highest mortality rate in the United States right now. Major problem. And what's led to this fuel of liver cancer rates is hepatitis C, fatty liver, and the other causes of cirrhosis as well. So, people with cirrhosis, as Simon mentioned, we want to screen for liver cancer. We do ultrasounds every 6 months. We also recommend, it's a little controversial, blood test called AFP every 6 months. A little controversial because they're not very sensitive or specific for liver cancer. Now, someone's overweight, right? 200, 300 pounds. Are you going to see a little tiny little tumor on the ultrasound? No. And when someone's got cirrhosis, the liver looks smooth, like a baby butt. No, it looks hard and nodular. So if someone's overweight, what we're doing is we're doing a CT scan once a year. I know Simon's laughing over there, and that's crazy. And he's right. Now, Recommended Liver Society, we did a survey of all the liver doctors in Los Angeles at Cedars-Sinai, USC, Loma Linda. Guess what? People high risk of missing a tumor, we are doing ultrasounds, all through the CT scan every 6 months. And someone's got cirrhosis. If you catch it early enough, we could reverse cirrhosis. If you have someone's got hepatitis C and they have incipient cirrhosis, there's a 17-20% chance of reversing cirrhosis. Same with hepatitis B. But if someone comes to your office, they have a big spleen, their eyes are yellow, their platelet count's 85,000, you're not going to reverse cirrhosis. But in milder cases, there is a possibility. And someone who you can't reverse cirrhosis, which the majority of patients cannot, the ultimate therapy is transplantation. Reverse the liver. Now be careful, there's a lot of things that cause cirrhosis in the first place. Hepatitis C, fatty liver, may come back after transplantation. People need long-term follow-up. This is a paper we wrote a number of years ago looking at how do we follow patients with cirrhosis. Depending on the severe liver disease, we may do blood work every 3 to 6 months, clinic every 6 months. Make sure we screen for varices and liver cancer. And recommend a low-salt diet. Avoid raw fish and shellfish, but those are associated with Vibrio. Could be fatal in people with liver disease. Avoid non-steroidals, aminoglycosides. Ask them about their quality of life, about pruritus and leg cramps, reversible brake cycle, and encephalopathy. So, the treatment of cirrhosis revolves around prospective medicine, asking the patient these questions about what impacts their quality of life. Make sure we stay on top of screening for varices and liver cancer. Active management revolves around the care of portable complications, ascites, varices. And for most patients with cirrhosis, most patients with advanced liver disease, the ultimate therapy is liver transplantation. So at this point, I want to thank you for the kind invitation. Where's Kevin? Thank you, Kevin. And thank you for coming today.